Hello everyone, welcome to my channel. We are starting our medicine part B section and we are having the units GIT, infectious diseases, nephrology, dermatology, liver and biliary system in the medicine part B section. So we will discuss each chapter one by one. We are starting from the GIT. So the important 10 topics that we will discuss in the GIT are given below. These are peptic ulcer disease, esophageal carcinoma, celiac disease, Crohn's disease, ulcerative colitis, acute pancreatitis, gastric carcinoma, and achalasia. So, starting from our first topic of the medicine, that is of GIT, that is peptic ulcer disease. We are having a scenario that there is a 45-year-old patient having epigastric pain which relieved by food. 2 weeks by he passed black stools with similar attacks for which he was admitted to hospitals and treated. HB was 12 gram, TLC per DLC normal, LFT is normal, and serum amylase normal. Another scenario is that there is a 40-year-old patient cigarette smoker having history of recurrent epigastric pain over last 2 years. Pain is mostly on empty stomach and the point site of pain by putting his finger on epigastrium. Using non-steroidal anti-inflammatory drugs off and on for painful joints. History of black stools in past. On examination, abdomen is soft. No visceromegaly is present. HB is 11 gram per dl and the TLC count is 6500 per centimeter cube and with the normal differential count, normal platelet count and normal liver function test. The another scenario is that a patient having heartburn for 1 year, he is heavy smoke. So what is the diagnosis, the investigation, the treatment, the complications and the counseling for this patient? So we are having the definition for peptic ulcer disease is that the formation of ulcers that occur in any portion of GIT caused by action of gastric secretions and impaired mucosal defenses. It occurs in the first portion of duodenum and the lesser curvature of the stomach adjacent to ileum and mecal diverticulum. The causes of peptic ulcer disease are chronic use of NSAIDs and aspirin, steroids, smoking, H. pylori infection, H. pylori gram-negative rod and fecal oral and oral route. These are the causes of peptic ulcer diseases. The clinical features are burning epigastric pain, pain worst at night, and pain is due to the gastric ulcer is aggravated with food. Pain due to duodenal ulcer is relieved with food. Okay, you should remember this point that the pain due to gastric ulcer aggravate with food and the pain due to duodenal ulcer relieve with food. Occasional vomiting and weight loss is present. The complications of peptic ulcers are bleeding, which is most common, gastric ulcer from erosion of left gastric artery and from erosion of gastroduodenal artery, perforation is present, shock and decreased BP and increased respiratory rate. Gastric outlet obstruction is present in the pylorus region. Pancreatitis is present. Malignant transformation, that is gastric ulcer associated with 1 to 4 increased risk and duodenal ulcer is never malignant. Okay, gastric ulcer is more associated with malignancy while duodenal ulcer is not malignant. The investigation options for peptic ulcer are endoscopy, which is choice of investigation, and screening for H. pylori is done. Okay, the different investigations and its advantages and disadvantages are mentioned. These are the non-invasive tests and these are the invasive tests. In non-invasive test, we are having the serology of serum antibodies. This is cheap and it is and if it is negative, it shows that there is no infection. This is the advantage of serology test. The disadvantage is that if it is positive, then it cannot differentiate between current and previous infection. Another investigation is C313 urea breath test. If it is positive, it shows active infection, and the disadvantage is that it requires expensive equipment. Another investigation is fecal antigen. If it is positive, then it shows active infection, and if the disadvantage is that its accessibility requires stool samples. Okay, now the invasive tests are endoscopy biopsy, which is most accurate of the all. Rapid urease test, which is cheap and quick and specific, and the microbiological culture, which is gold standard and defined antibiotic sensitivity. So these are the investigation options of the peptic ulcers. Now the treatment option for peptic ulcers are, if H. pylori is positive, then eradication therapy is given. The eradication therapy is PPI and antibiotics for 14 days. And antibiotics are amoxicillin, clarithromycin, metronidazole, tetracycline, and bismuth. For example, the regimens are okay. The total regimen for the peptic ulcer is triple therapy, that is omeprazole, clarithromycin, and amoxicillin, which are antibiotics. Triple therapy is used if the patient is resistant to triple therapy. Then quadruple therapy is given in eradication if failure of 14 days of occur. Okay, the triple therapy is given for 14 days, and if it fails, then quadruple therapy is given. The options are bismuth chelate, metronidazole, tetracycline, and PPIs. Now, coming towards the general treatment, no smoking should be done. Avoid aspirin, avoid alcohol. Okay, the acid suppressions are given, which are H2 receptor blockers, that is ranitidine and famotidine. Then PPIs are given, which are omeprazole and pantoprazole. Drug enhancing mucosal defense, that is sucralfate and bismuth compound. Antacids are given, which are syrup containing magnesium and aluminium. Surgical options for peptic ulcer disease are partial gastrectomy and vagotomy and Billruth 1 and Billruth 2 operations. So we have discussed the topic peptic ulcer disease. We have discussed the three scenarios that a patient will come with, what type of symptoms and signs, and what will be the diagnostic points. Then we discussed the definition, then the causes of the peptic ulcer, then what are the clinical features. Then we discussed the complications, then the investigation options, which are both the non-invasive and invasive. Then we discuss the treatment options for pylori, that is the eradication therapy. We will give the triple therapy, and if it fails, then the quadruple therapy is given. Now, coming towards the next topic, that is esophageal carcinoma. Okay, so the scenario for esophageal carcinoma is that there is a 60-year-old male with 6 months history of progressive dysphagia for solids. On examination, he is wasted and pale looking. Wasted means that he is having weight loss. A 60 years old Afghani, progressive difficulty in swallowing, problem with solids but now unable to swallow liquids as well. On examination, he is wasted and anemia is present. The rest of examination is unremarkable. So, what is the diagnosis, the investigation, and the treatment? We are having the definition for esophageal carcinoma is that it is the most common more male dominant upper and middle third of the esophagus carcinoma. The clinical features are asymptomatic and the age is greater than 55 years. Dysphagia is there, weight loss is present, anorexia and bleeding, hoarseness and chest pain is present. The metastasis is towards the liver, the lungs, the brain, and the bones. The investigation options for esophageal carcinoma are upper GI endoscopy, which is the investigation of choice. Biopsy and cytology is also the investigation of choice. Then CT scan of thoracic and abdominal is done to identify metastatic spread and local invasion. X-ray chest and ultrasound abdomen is done for metastasis. Endoscopic ultrasound is done, which is the most sensitive method for the method of penetration of tumor and detecting involving lymph nodes. Then barium swallow is done, which shows narrowing of the lower end and red tail appearance. The treatment options for esophageal carcinoma are surgery, which is the resection surgically is treatment of choice, and confine tumor to the esophagus only. Chemotherapy is done, the chemo with 5-fluorouracil used before surgery in some centers. Then radiotherapy is done for the squamous cell carcinoma, respond to radiation, while adenocarcinoma is less radiosensitive. Palliative treatment for non-operative operable tumor, stent, and photocoagulation is done. So we have studied the esophageal carcinoma, the scenario, the diagnostic points, then the definition, the clinical features, then the metastasis of the carcinoma, then the investigation options, and then the treatment options. Now coming towards the celiac disease. We are having a scenario that there is a patient of 30 years old female, chronic diarrhea, bloating, flatulence is present, weight loss is present. On examination, BP is 100 by 70 mm of Hg and papillary rash over the trunk is present, and abdominal examination is unremarkable. So what is the diagnosis, the investigation, the skin manifestation, the complications, and the treatment? The definition of celiac disease is that it is a gluten-sensitive enteropathy characterized by intestinal mucosal injury resulting from immunologic intolerance to gluten in persons genetically predisposed to these conditions. The clinical features of celiac disease are female are having twice risk as that of male. Diarrhea, weight loss, and flatulence is present. Malnutrition is there. Osteoporosis is present. Anemia is present. That is microcytic from iron deficiency and macrocytic from folate deficiency. The skin manifestations are dermatitis herpetiformis, which is the itching, blistering skin in 10% of cases, characterized by intensely pruritic pupilovesicular lesions on extensor surface of the elbows, knees, and buttocks. Immunofluorescence shows IgA deposition at dermo-epidermal junction. The treatment options are gluten-free diet and Epsom, that is 100 to 150 mg daily. In children, that is in infancy, presents after weaning onto the cereal, then presents with diarrhea, malabsorption, and failure to thrive. In children, growth and puberty delay and short stature. Okay. In the investigation options for celiac diseases are routine tests, that is CBC for anemia, serum ferritin, serum vitamin B12, PT or APTT. Then the specific tests are done, which are endoscopic biopsy, gold standard jejunal biopsy, small bowel follow through, give characteristic morphological treatment. It is common in duodenum and proximal jejunum, chronic intraepithelial infiltrant lymphocyte, villus atrophy, and blunting and crypt hyperplasia is present. Anti-tissue transglutaminase IgA antibodies are present, which are excellent screening test, and it is more accurate in patients with IgA deficiency. Anti-endomysial IgA antibodies, that is sensitivity 85 to 95%, specifically 100%, excellent screening test. Then anti-gliadin IgA antibodies, that is sensitivity is 80% and specificity is 85%, and it is moderately good screening test. The treatment options are lifelong gluten-free diet, omission of wheat, rye, barley, and oats. Then the correction of deficiencies, that is iron, folate, calcium, and vitamin D. Then the refractory cases, that is corticosteroids and immunosuppressants are used, and corticosteroids are used for diarrhea. Okay, so we have discussed the case of celiac disease, in which we are having a female having chronic diarrhea, bloating, and flatulence and weight loss, and examination BP is 100/70. So, what is the definition of celiac disease? And we discussed the clinical features and the skin manifestations that specifically occur in the celiac disease, which are dermatitis herpetiformis. Then in children, infancy, and in children, then the investigation options, which are routine investigations and specific tests. The specific tests are endoscopic biopsy, anti-tissue transglutaminase IgA antibodies, anti-endomysial IgA antibodies, anti-gliadin IgA antibodies, and then the treatment options. Now coming towards the Crohn's disease. For Crohn's disease, we are having a scenario that there is a 26-year-old male, 2-month history of abdominal pain, loose motion, and weight loss. On examination, he is pale with oral ulcer and tenderness in the lower quadrant, and FBC shows HB 9 g/, TLC normal, serum albumin with normal TFTs. Another scenario is that there is a 29-year-old school teacher, 2 years history of low-grade fever and episodes of loose motion with mucus, lost weight with aphthous ulcers in mouth, and on examination, he is anemic, abdomen is tender, and palpable mass is present in the right iliac fossa. The rectal examination shows a perineal abscess. So the diagnosis, investigation, treatment, complications, management, differential diagnosis, and the counseling of the patient. Okay, now Crohn's disease and ulcerative colitis are the inflammatory bowel disease. So Crohn's disease is an inflammatory bowel disease, and the clinical features are lower quadrant colicky pain with diarrhea and bleeding with colon or anal, and anal fissures and anal fistulas are present. Calculi, that is calcium oxalate, may present, and pernicious anemia is there. The investigation options for Crohn's disease are CBC, that is anemia is present, raised ESR and CRP, C-reactive protein due to infection, and ASCA is positive, that is antisaccharide cervician proteins. Barium follow through and contrast enhanced CT scan of the abdomen is done. Colonoscopy is done if colonic involvement is suspected, and endoanal ultrasound and MRI is done for perineal diseases. The management options for Crohn's disease are diet, that is avoid dairy products of lactose intolerance, it is common with Crohn's. Then fiber supplements are given, low fat diet is given, and supplements of the iron, folic acid, and zinc and vitamins is given. TPN, that is total parenteral nutrition, may be beneficial for short term to relieve the mass. Then symptoms or symptomatic treatment for the diarrhea is given, that is cholestyramine, and it bind bile salt responsible for secretory diarrhea. Then the specific drugs are given, which are corticosteroid, that is prednisolone 40 to 60 mg tapering after 2 to 3 weeks for 4 to 5 weeks continuous. Immunosuppressive therapy is given, that is azathioprine. Anti-tumor necrosis factors are given, which is infliximab. Acute exacerbation of the Crohn's disease, we will give the antibiotics, that is fluoroquinolones, metronidazole for perineal disease, and mild moderate corticosteroids are given, and if no response to steroids, then infliximab and cyclosporins are given. The surgical options are done when there is failure of medical treatment and in case of complications and failure to grow in children. Okay, the counseling for the patient of Crohn's disease is that introduce yourself, then educate about the disease, then tell him all life cycle changes which he has to adopt, that is proper hydration, smoking cessation, regular exercise, and enough sleep. Then encourage to take small meals and drink enough water to prevent constipation. Then tell him to take multivitamins and high protein and low fiber diet, and then thanks the patient. The complications of Crohn's disease are abscess formation, obstruction, carcinoma, fistula, and perforation. The differential diagnoses of Crohn's disease are amoebiasis, appendicitis, bacterial gastroenteritis, celiac disease, diverticulitis, and giardiasis. Okay, so we have discussed the topic Crohn's disease, the scenario for Crohn's disease. Then we discussed the clinical features and investigations, the management, that is diet and TPN, then the symptomatic treatment for diarrhea, then what are the specific drugs, then the immunosuppressive therapy, then the anti-TNF, then acute exacerbation of the Crohn's disease, then mild to moderate, and the surgery and the counseling options and the complications and the differential diagnosis. Now coming towards the next inflammatory bowel disease, that is ulcerative colitis. We are having a scenario that there is a 30 years old male presented to emergency. There is history of loose stool with blood and has tenesmus, passing stool 6 to 8 times per day. History of fever and abdominal pain is present on examination. He looked toxic, pale and dehydrated and febrile. Another scenario is that there is a 50-year-old man, non-smoker, history of tenesmus, passage of mucus, bloody diarrhea, periods of relapses and remissions over the last 3 years. He noticed relapses are provoked by emotional stress and indiscriminacies, use of antibiotics and NSAIDs, has lost 3 kg weight in the last 3 years. So the diagnosis, investigation, complications, treatment, and the extraintestinal manifestation of this disease. So the investigation options for the clinical features are left-sided abdominal crampy with bloody diarrhea. The investigation options for ulcerative colitis are blood CB, that is iron deficiency anemia, raised ESR and CRP, and PANCA is positive, stool culture to exclude infective causes of the colitis, plain abdominal X-ray, that is lead pipe appearance from loss of ostration, then colonoscopy plus sigmoidoscopy, which is a feature of ulcerative colitis, then barium enema in ulcer and colonoscopy to see extent and to see the biopsy. The complications of the ulcerative colitis are toxic megacolon and hypotoxic and distended bowel, adenocarcinoma of the colon, fistula, abscess, bleeding, perforation, stricture, and carcinoma. The extracolonic manifestations are primary sclerosing cholangitis, ankylosing spondylitis, migratory polyarthritis, pyoderma gangrenosum, erythema nodosum, uveitis, episcleritis, and thromboembolic events. The treatment options are general, specific, and surgical. In general, we are having the diet control, that is caffeine and gas producing should be avoided. Fiber supplements are given and antidiarrheals are given. The specific measurements are mesalazine is given, hydrocortisone is given, immunosuppressants is a thiopurine is given, and oral aminosalicylates is given, plus rectal steroid are given, and the antibiotics are given for infective diarrhea. The surgical interventions are done in case of the medical fail, and the surgical options are protolectomy and ileostomy. So we have discussed the topic ulcerative colitis and the scenario of the ulcerative colitis, the clinical features, and we discussed the investigations, which are blood CP, raised ESR and CRP, and ANCA, that is stool culture, plain abdominal X-ray, colonoscopy and sigmoidoscopy, barium enema, and colonoscopy. Now then we discussed the complications, the extracolonic manifestations, and the treatment options, which are general, specific, and surgical. Now coming towards our next topic, that is acute pancreatitis. We are having a scenario that there is a 40-year-old female patient having 4 days history of epigastric pain and which is radiating to the back. Vomiting is there on examination, tenderness with guarding in epigastrium and no previous attacks. Serum amylase is 800 and the normal range is less than 125, and epigastric tenderness is there. So, what are the diagnosis, investigation, treatment, complications, and differential diagnosis? The acute pancreatitis is the acute inflammation of the pancreas, and the causes are gut smash, that is gallstones, ethanol, trauma, steroids, mumps, autoimmune, scorpion venom, hyperlipidemia, endoscopy, drugs, that is thiazides and diuretics, and azathioprine. The differential diagnoses are perforated peptic ulcer, acute cholecystitis, acute intestinal obstruction, MI, vasculitis, pneumonia, DKA. The clinical features are severe constant abdominal pain, pain radiating to back, sitting forward may relieve, nausea and vomiting is present, fever, tachycardia, jaundice, and parumbilical discoloration and flank discoloration. The investigation options are serum amylase is increased in first 24 hours, then serum lipase is increased, which is more sensitive and specific. CT scan contrast enhanced, more sensitive and specific. Abdominal X-ray is done for gallstones. WBC shows leukocytosis. AST is raised, LDH is raised, and ultrasound shows stones in the gallbladder. So the treatment options for the acute pancreatitis are supportive, that is bed rest, nail per oil, intravenous fluid, single rectate, dextrose water is given, nasogastric suction with Rayleigh's tube, then pethidine is given 3 to 4 orally for pain, that is morphine, O2 if respiratory distress, calcium gluconate intravenously given, insulin for hyperglycemia is given, total parenteral nutrition is given if required, and injection vitamin K is given. The specific measurements for acute pancreatitis is broad spectrum anaphylactic antibiotics, for example, cefixime. Then ERCP may be required if stones or obstructions and open surgery is done. The complications options the complications of the acute pancreatitis are systemic organ failure, shock, disseminated intravascular coagulation, hypoxia, pancreatic abscess, hyperglycemia, pancreatic pseudocyst, necrosis, chronic pancreatitis, and obstruction. So we have discussed the case of acute pancreatitis, the scenario for it, then the causes which can be remembered from the mnemonic get smashed, and the clinical features, the investigations, then the treatment options which are supportive and specific, then we discuss the complications. The next topic is gastric carcinoma, which is most common malignant tumor of the stomach, and the clinical features are asymptomatic weight loss, anorexia, epigastric pain, and ocular bleeding, iron deficiency anemia, and neoplastic skin lesions is present. The investigations options are upper GI endoscopy, which is indication of choice. CT scan is done for space staging, and laparoscopy, which detect peritoneal spread and determines the tumors that it is resectable or not. The treatment options are surgery, which is only hope of the cure, and it is curative in 90% of the patients with early gastric cancer. The chemotherapy is given perioperative chemotherapy with cisplatin, and thiouracil is given. Another topic is achalasia. We are having the definition that it is esophageal motility disorder with 3 major abnormalities. The causes of achalasia are it is not alcohol. The causes are idiopathic. Chagas disease may be the cause. Diabetic autoimmune neuropathy may be present. Amyloidosis may be present. Sarcoidosis and pseudoachalasia. The clinical features are dysphagia, that is difficult swallowing, weight loss, age greater than 50 years, nocturnal cough, regurgitation, and retrosternal chest pain. The investigation options that are done for achalasia are chest X-ray, which shows the air fluid level is in dilated esophagus and wide mediastinum, absent gastric bubble, and pulmonary infiltrate. Esophagoscopy is done to exclude submucous infiltrating carcinoma of lower end of the esophagus and esophageal structure. Barium swallow is done that shows the bird's beak appearance, esophageal dilatation with confirmed tapping of the distal esophagus. Esophageal manometry is done, which increase resting pressure in the lower esophageal sphincter and decrease peristalsis in the body of esophagus. The treatment options for achalasia are non-pharmacological, which are dilatation, endoscopic injection of the botulinum toxin into lower esophageal sphincter, calcium channel blockers, nitrates, and surgical Heller's myotomy. The complications are squamous cell carcinoma, candida, esophagitis, diverticulitis, aspiration pneumonia, and airway obstruction. So we have discussed the case of achalasia, which is esophageal motility disorder. We discussed its causes, the clinical features, then the investigation options, which are chest X-ray, esophagoscopy, barium swallow, esophageal manometry, then the treatment options, which are non-pharmacological, and at the end we discuss the complications. In the next video, we will discuss the hematology, that is the blood and its all disorders and leukemias, etc. Thanks for watching.